gewoon nog leef natuurlijk.
On voit l'être aimé complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva succedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial. Parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen. and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν, και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout était autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an intensive care nurse, and I'm proud to work with a multidisciplinary team to work together to fight COVID-19. Together, we are intensive care medicine.
I'm an anaesthetist, and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm a primary intensivist, and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist, and I'm proud to be an intensivist. We intensivists working together to fight the COVID-19. Together, we are intensive care medicine.
I am a surgeon, and I'm proud to be an intensivist as well. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello to all of you. I am Xavier Monnet. I work in the medical intensive care unit of the Bicêtre hospital in Paris. I am the chair of the cardiodynamics section of the ESICM, and Bernd Saugel is the co-chair. And we are very proud and very happy to offer you today the opportunity to attend this webinar on hemodynamic monitoring. Michelle, please introduce the webinar.
Great, thank you very much, Xavier, and thank you to all of us for joining us on this afternoon. My name is Michelle Chu. I'm Professor in Intensive Care Medicine and Anaesthesiology at Linköping University Hospital in Sweden. Now, it's my absolute pleasure to welcome Professor Xavier Monnet and Bernd Saugel today. Okay, so Professor Saugel is disconnected, but we'll try to get him back on, not to worry.
Yes, we can.
Sure. So let me just tell you a little bit more about this webinar. We're, of course, really delighted that you can spend a few of your precious minutes with us. I know that you all have a heavy workload at the moment, and I know also that Professors Monnet and Saugel are more than willing to share their vast knowledge in hemodynamic monitoring with you today. I know you have lots of questions. Do go on your social media, whatever you have, and do go on the website chat if you do have any questions, and we will endeavor to answer them as best as we can within the session. Now, I'll tell you a little bit about Professor Monnet. He really deserves no introduction because you all know him, but I cannot help because I am so proud of his achievements. He's a professor at Paris-Saclay University Hospital, and you will know him from his seminal works in fluid and preload responsiveness, passive leg raising. You've all seen the diagrams, and hemodynamic monitoring. As he mentioned himself today, he's the chair of the current chair of the cardiodynamic session. And Professor Bernd Saugel is a professor and vice chair at the Department of Anaesthesia and Intensive Care Medicine at Hamburg University Medical Center. And he has a very prolific history in writing about predictive monitoring, perioperative hypertension in the critically ill, and novel monitoring methods, which I'm sure he'll be happy to share with you today. Some of you may have attended the recent masterclass in hemodynamic monitoring, a very successful 3 days run by Xavier and Bernd just last week. So welcome back to those of you who are joining us today. So Professor Saugel is back, and I am delighted, absolutely delighted that you are back, Bernd, and we've just introduced you. Thank you for spending time with us today. Welcome.
Thank you very much. Can you hear me now? Very good. So I will start sharing my screen, and we should be ready to go. Can you confirm that you hear me and that you can see my screen? Very good. So thank you very much, Michelle, for the very nice introduction. Hello, good afternoon from Hamburg in Germany. I'm very happy to open this very interesting webinar on which hemodynamic monitoring tool, with discussing with you which hemodynamic monitoring tool we should use in the operating room. So these are my conflicts of interest. And if we think about our main hemodynamic treatment goals that we have in patients during surgery, of course, you will agree that we need to optimize perfusion pressure and oxygen delivery. To optimize perfusion pressure, we need to optimize blood pressure, especially mean arterial pressure, and to optimize oxygen delivery, we need to optimize blood flow. This is cardiac output that is mainly determined by stroke volume and heart rate. Excuse me, say it again. Are we good? Okay, thank you. Sorry for that. So what we want to focus on today is blood pressure monitoring and blood flow monitoring in the operating room. So let's start with a more easy hemodynamic variable to monitor, and that is blood pressure. Why is blood pressure monitoring important? You all know that in patients having non-cardiac surgery, there is an association between intraoperative hypotension, that is low blood pressure during surgery, and postoperative organ injury. I could show you numerous retrospective registry studies that show that there's an association between the lowest mean arterial pressure during surgery and the risk for developing postoperative acute kidney or acute myocardial injury. In addition to those studies showing an association between hypotension and adverse outcomes, we also have one small randomized control trial suggesting that individualized targeted blood pressure management improves postoperative organ function compared to routine blood pressure management. So blood pressure monitoring and blood pressure optimization is key in patients during surgery. So the next question then is, how should we monitor blood pressure? In the operating room, we can measure blood pressure invasively or non-invasively. In the vast majority of patients, we monitor blood pressure non-invasively using intermittent measurements with oscillometry based on an inflatable occluding upper arm cuff. So what is the measurement principle of oscillometry? You know that blood pressure changes are transmitted from the arteries into the surrounding tissue of the upper arm. And those tissue pressure changes cause oscillations in the air-filled cuff, and those are detected by a pneumatically coupled sensor. So we inflate the cuff to pressures higher than systolic blood pressure. This occludes the artery, and during deflation of the cuff, we alter the amplitude of tissue pressure oscillations, and by definition, the oscillations with the highest amplitude reflect mean arterial pressure, and systolic and diastolic pressures are then derived using proprietary algorithms. You will probably agree that intermittent automated oscillometry is considered a clinical reference method by many anesthesiologists, and we need to admit it is easy to use, it is non-invasive, but of course it provides blood pressure readings only intermittently. It depends on the correct cuff size and positioning of the cuff, and the measurement performance of oscillometry is worse than generally assumed. Let me put some numbers around this. This is an interesting study comparing oscillometry versus invasive blood pressure monitoring from radial arterial catheters in more than 15,000 patients having surgery. The average difference between the upper arm cuff and the radial arterial catheter was pretty low, but a high standard deviation suggests that there is a relatively low precision of agreement. This is better illustrated in a figure, and here you can see the mean arterial pressure on the x-axis and the difference between oscillometry and the arterial catheter on the y-axis. And what you can see is that oscillometry underestimates high blood pressures and it overestimates low blood pressures. Therefore, in high-risk surgery patients having major surgery, we measure blood pressure directly using an arterial catheter. And you all know that this requires that we level the pressure transducer to the anatomic height of the right atrium, because the right atrium is close to the level of the aortic root. And we need to be careful in patients having surgery in the sitting position, because we need to ensure optimal cerebral perfusion pressure, and therefore we might adjust the transducer to the level of the ear. In addition to that, we need to check the quality of the arterial blood pressure waveform. In clinical practice, we perform a fast flush test by flushing the valve of the pressure bag of the tubing system. A fast flush test looks like this in a normal, non-distorted wave, and we can identify underdamped arterial pressure waveforms. Here you can see those non-physiologic oscillations in the diastolic phase. You can see a deep diacrotic notch. Systolic pressure is overestimated and diastolic pressure is underestimated. And just the opposite is true in overdamped signals. So you hardly see any diacrotic notch. Systolic pressures are underestimated and diastolic pressures are overestimated. So direct blood pressure measurement, of course, remains a clinical reference method. It is continuous, provides measurements in real time. Yes, it is invasive, but major complications are very, very rare. It depends on correct transducer leveling and the dynamic response. The damping of the system is important. We now want to look at a study that compared continuous blood pressure measurements from arterial catheters with intermittent oscillometry in patients having non-cardiac surgery, and blood pressure monitoring with arterial catheters. Continuous monitoring detects nearly twice as much hypotension as intermittent oscillometric measurements. There is now a third option for blood pressure monitoring, and that is continuous non-invasive monitoring using finger cuffs. How do these relatively new technologies work? You have a finger cuff with an infrared light source and light detector. This finger cuff is inflatable, and the finger cuff keeps the blood volume in the finger arteries constant throughout the cardiac cycle. From the cuff pressure that is needed to keep the arterial blood volume constant, the continuous blood pressure waveform can indirectly be derived. We recently compared in one study in the same patients finger cuff technologies versus arterial catheters and simultaneously oscillometry versus arterial catheters. And what we found is that the agreement between those innovative finger cuff and arterial catheter was superior to the agreement between oscillometry and invasive measurements. This again is a randomized controlled trial. Authors compared continuous finger cuff monitoring versus intermittent oscillometry. And in this study, the primary endpoint was the time-weighted average mean arterial pressure below 65. That is the area under the threshold of 65 divided by the duration of surgery. And the time-weighted average mean arterial pressure, so the amount and duration of intraoperative hypotension, was lower with continuous finger cuff monitoring compared to intermittent oscillometric measurements. So those relatively new, innovative, continuous non-invasive finger cuff systems are easy to use. They are non-invasive, they provide measurements continuously and in real time, but we need more measurements, more data on the measurement performance. It's maybe better than oscillometry. And of course, there are imminent technical limitations regarding, for example, patients with impaired finger perfusion. So let's now talk about blood flow monitoring, so monitoring of stroke volume and cardiac output. Why should we monitor blood flow? Why should we monitor cardiac output? There is some evidence that cardiac output-guided hemodynamic management improves postoperative outcomes compared to routine management. And of course, all of you are familiar with the OPTIMIZE-1 trial that was published in 2014 in the JAMA, and the authors tested the hypothesis that cardiac output-guided hemodynamic management reduces a collapsed composite endpoint of major postoperative complications and death compared with routine management in patients having major gastrointestinal surgery. The primary endpoint, the composite of complications and death, occurred in 43% of the usual care group patients and in 37% of the cardiac output-guided group patients. And this difference, in my personal opinion, is clinically relevant, but the results failed to be statistically significant. We recently published a randomized controlled trial and tested whether personalized hemodynamic management, again based on cardiac index, improves the outcome of patients having major surgery, again compared to routine care. Our composite was very similar, also a composite outcome of postoperative complications and death within 30 days. And this primary endpoint occurred in 55% of routine group patients and in 30% of patients treated with cardiac output-guided personalized management. This was clearly clinically relevant and statistically significant, but was only tested in a monocentric trial. So there is some reason to monitor cardiac output and to optimize cardiac output, and we have numerous methods to measure cardiac output. The invasive methods are mainly indicator dilution methods. Those will be mainly discussed by the next speaker because they are mainly used in the intensive care unit. So just a few words. Those indicator dilution methods are pulmonary artery thermodilution with the pulmonary artery catheter, or transpulmonary thermodilution with a dedicated arterial catheter and a central venous catheter. And to be clear about this, routine use of the pulmonary artery catheter is right now not recommended in patients during non-cardiac surgery. And this is a statement that has been published more than 5 years ago by the European Society of Anaesthesiology and the European Society of Cardiology. So in the operating room, we need to rely on less invasive, minimally invasive methods like esophageal Doppler or pulse wave analysis. You know that the esophageal Doppler can estimate stroke volume by the velocity time integral and the cross-sectional area of the aorta. And pulse wave analysis can estimate stroke volume based on the properties of the blood pressure waveform. So pulse wave analysis can estimate stroke volume and cardiac output and stroke volume variation and pulse pressure variation that can be used as dynamic cardiac preload variables. Of course, the waveform is not only influenced by stroke volume, but also by the aortic compliance and systemic vascular resistance, and therefore estimating stroke volume just from the waveform is challenging. Pulse wave analysis can be classified into invasive, minimally invasive, and non-invasive methods. Invasive methods allow calibration to an external reference cardiac output value, and those methods will be mainly discussed for our patients in the intensive care unit by the next speaker. In the OR, we mainly use minimally invasive methods, and those are internally calibrated. That means they are calibrated based on demographic, biometric, and waveform data, or they are totally uncalibrated. That means they only estimate stroke volume based on waveform features. There are now also non-invasive methods, again based on finger cuffs, that are all internally calibrated. What about their measurement performance? Internally calibrated pulse wave analysis compared to transpulmonary thermodilution shows very good agreement in generally critically ill or general surgical or post-surgical patients, but we need to be cautious because the measurement performance is worse in patients with marked changes in systemic vascular resistance, for example, patients having liver surgery or sepsis. So what are the concrete recommendations for patients having surgery? What type of cardiac output monitoring should we use? Well, first of all, we might ask ourselves, do we speak about patients having cardiac surgery or non-cardiac surgery? In cardiac surgery patients, there's a clear indication for advanced hemodynamic assessment and monitoring. We usually use transesophageal echocardiography, the pulmonary artery catheter, or in selected cases, for example, lung transplantation, transpulmonary thermal diffusion. In non-cardiac surgery patients, we need to consider the patient's risk. In high-risk patients, there is a clear indication for cardiac output monitoring and goal-directed optimization. And we might ask, is there liver failure or sepsis? If this is the case, we should use externally calibrated pulse wave analysis. But in most of the patients, of course, this will not be the case, and we will be good to go with invasive, internally calibrated or uncalibrated pulse wave analysis. In low-risk patients, we are probably good with basic hemodynamic monitoring and may consider to get more information from totally non-invasive pulse wave analysis devices. So to summarize, regarding blood pressure monitoring in the operating room, we mainly use intermittent oscillometry based on air-filled cuffs. It is the most frequently used method. We have a lot of confidence into the method, but we need to know that it overestimates low blood pressures and therefore may miss hypotension. Continuous invasive direct blood pressure monitoring with arterial catheters, of course, is a clinical reference method. It provides measurements continuously and in real time. It detects more hypotension than oscillometry. It is invasive, but major complications are rare. And now we could also use continuous non-invasive finger cuff methods. They are easy to use. They provide measurements continuously and in real time. They detect more hypotension than intermittent oscillometry, but we need more data on the measurement performance. Regarding cardiac output monitoring, indicator dilution methods are the clinical reference method, but they are rarely used during non-cardiac surgery. We therefore need to measure or estimate stroke volume and cardiac output based on pulse wave analysis or the esophageal Doppler. And based on current evidence, cumulative evidence suggests that in high-risk surgical patients, goal-directed cardiac output-guided therapy may improve postoperative outcomes, but there are several large ongoing trials. First of all, the OPTIMIZE-2 trial that will hopefully give us a definite answer whether we should monitor and optimize cardiac output in high-risk patients having major surgery. Thank you very much for your attention. I'm very much looking forward to the discussion at the end of the webinar.
Well, Professor Saugel, I really want to thank you very much for that excellent evidence-based summary of current literature with a huge number of studies summarized for us, so we don't have to do any of the work ourselves. And some very important clinical messages as well and insights into new technologies. So thank you very much for that. And now I would like to introduce Professor Xavier Monnet, who will give us a lecture on hemodynamic monitoring in the intensive care population. Welcome.
Thank you very much, Michelle. And again, hello to all of you. Of course, I start my presentation by stating my disclosures, especially with Pulsion Medical Systems and with Bicêtre, which develop some devices I will speak about during this presentation. I think that the first question that we may ask every day is, should we monitor cardiac output in our patients? I mean, let's take the example of a patient, a typically critical ill patient, community-acquired pneumonia on day 1, and the PEEP is high and the patient has ARDS. And he or she has already received saline and is under 0.2 of norepinephrine. At that time, do we set up a cardiac output monitoring device, or do we use blood pressure only? Should we insert a PA catheter, a PICO device at that time in this patient? Because you all agree that if we do not monitor cardiac output, it means that we will monitor the patient with a simple blood pressure of the bedside monitor. Is it the same? Basically, physiology tells us it is not the same. Why? Because it is obvious that the peripheral blood pressure that you can measure with a catheter, an arterial catheter, is determined by cardiac output. One of its determinants is cardiac output, but also obviously, and as said by Bernd Saugel in the previous talk, it's also determined by the properties of the arterial tree, which is between the heart and the peripheral artery. And so the question is, in patients where the arterial resistance, the properties of the arterial tree change a lot, can we still rely on blood pressure to look for changes, to track the changes in cardiac output? This is in fact the question we are asking. Do blood pressure changes reflect cardiac output changes when resistance, arterial resistance changes? To answer this very simple question, we conducted this very simple study 10 years ago. Patients who received volume expansion, meaning no change or almost no change in arterial resistance, and patients where we increased the dose of norepinephrine, of course, increasing the arterial resistance. And we wanted to know whether, for monitoring the true changes in cardiac output, we could rely on blood pressure or not. Look, the results are on one slide, this one. Volume expansion, there was a relationship, but it was a very rough relationship between the changes in arterial pulse pressure and the true changes in cardiac index. But in patients where norepinephrine was increased, you see that there was no correlation at all between the changes of arterial pressure and the changes in cardiac output. What is written on this slide is that in these complex patients, in whom we want to know exactly, where we want exactly to know what happens, in these patients with changes in resistance due to septic shock, to norepinephrine, to dobutamine, etc., we need to monitor cardiac output directly. And these results, and the results were even poorer in this other study by the team of Jean-Louis Vincent. Look, they gave fluid. There was no correlation between the changes in pulse pressure this time and the changes in cardiac output. So it was even worse than in our study, perhaps because they use a radial artery, we use the femoral one. The message is the same. In these patients, we need to monitor cardiac output. It means that basically we need a basic ICU monitoring, which is an A line with blood pressure, many hemodynamic information, a CV line, and baseline echocardiography. It's not our topic today. We will give fluid to the patient, small doses of vasopressors, but if the patient does not improve, then it means that we need to monitor cardiac output. By the way, it was exactly what was stated by this recommendation by the society. We recommend cardiac output and stroke volume to evaluate the fluids or inotropes in patients that do not respond to initial therapy, which means patients who do not respond to volume expansion and small doses vasopressors. And this is likely the first important message we may bear in mind. We should monitor cardiac output in ICU patients who resist to initial fluid administration and low doses of norepinephrine. Blood pressure in these patients, blood pressure monitoring in these patients is not enough for assessing hemodynamics. Then, of course, the next question is, which hemodynamic monitoring device should we rely on for that? Because Years ago, the only monitoring device was the PA catheter, but today we have many of them. Some of them have been quoted and detailed by Bernd. Are all these devices suitable for our critical ill patients? And my message here is that all those devices are not equivalent. In fact, we have some non-invasive devices, the volume clamp devices, the bioreactance devices Bernd Saugel spoke about. We have some less invasive devices, just with a PA catheter on a soft gel probe, and we have the invasive devices. Transpulmonary thermodilation, it means the PICO and the volume view, which are equivalent devices. Lithium dilution with a PICO, I won't speak a lot about that. This device is mainly used in the UK, but we could say it's like transpulmonary thermodilation and the old PA catheter. In fact, the question here is, are the less or non-invasive devices reliable for our ICU patients? Is it the case, for instance, for the less invasive devices, for uncalibrated pulse contour analysis devices, Vigileo, Pulsoflex? As we heard from Bernd Saugel, and this is one of his slides, we know that these devices estimate cardiac output from an analysis of the waveform of the arterial pressure, and because it's related to stroke volume. But a major determinant of the pulse contour analysis is systemic vascular resistance. In other words, and again, if systolic vascular resistance changes, these uncalibrated devices are not reliable anymore. So it means they are not reliable for septic shock, for cardiogenic shock patients. It's been shown by many studies. I just show this one, which is very illustrative by the team of Maxime Canesson. Look, comparison between the changes in cardiac output with Vigileo, so uncalibrated pulse contour analysis, and the reference. They go in the same direction when they change cardiac output with preload manipulations. Changes do not go to the same direction in a large proportion of cases if they give a vasopressor, ephedrine, and it's even worse with epinephrine. In 80% of the cases, the direction is opposite with the uncalibrated device and the reference. And many studies have confirmed that these uncalibrated devices are less reliable in ICU patients. Let's look at non-invasive devices, for instance, the Starling bioreactance device. It's interesting. Look at the studies that have investigated the reliability of bioreactance, not bioimpedance, just bioreactance. And you have the values of the percentage error. Whatever it is, it must be below 30% for the device to be reliable. Look, you have some very good studies and some very bad studies. But it's very interesting. The good results were obtained in stable patients, in healthy subjects, in pregnant women, while the worst results were obtained where the arterial resistance changed a lot. ICU patients, liver surgery patients, butane stress. It means that these devices are not made for ICU patients, and the same for volume clamp. It estimates cardiac output, as said by Bernd, from the arterial pressure in the fingers. So, of course, you can easily understand that if there is strong vasoconstriction, it's very likely the the device is less reliable. In ICU patients, the worst results were observed. So it means that the less invasive, non-invasive devices are for high-risk surgical patients, likely not cardiac surgical patients, but non-cardiac surgical patients, while in the ICU, for our critical ill patients, we are left with the most invasive devices, transpulmonary thermodilation and the PA catheter. And in this review with Bernd Saugel, we clearly stated with this expert panel that non-invasive hemodynamic monitors are currently not recommended for use in patients with shock. These patients need arterial catheterization, and even more, the less invasive devices are less reliable. Keep that at the take-home message. TPT, the transpulmonary thymidulation devices, and the PA catheter are recommended devices for this purpose, for ICU monitoring. They are reliable and provide enough information. And actually, for the ICU, in the less severe patients, in the largest number of patients, we have these devices which are less or non-invasive, which are cheap, but which provide not that many pieces of information. Why? In the ICU, we must use invasive devices, sophisticated devices, which are unfortunately invasive and expensive, but in addition to their reliability, they provide more information. And this is very important because these patients are complex. What are the questions we are asking ourselves in this patient? Should they need fluid? Is fluid administration too dangerous? Is cardiac output adequate? How is the LV contractility? How is the right ventricle in ventilated patients? The less invasive devices cannot answer all these questions. For answering these questions, we need a PA catheter or a transpulmonary thermodilation device. For the last slides, let's review how these devices answer these questions for each of them. First, how much is cardiac output? As we have seen, less invasive devices are less reliable. With transpulmonary thermodilation, you need a standard central venous catheter. I guess that many of you know how these devices work, and you need a specific catheter. Specific because it has a thymistor at its tip. And the principle is that it uses transpulmonary thermodilation. When you inject a cold bolus in the circulation, the thermodilation curve at the other side of the circulation, with the arterial catheter in the femoral artery, provides cardiac output. It's reliable. Unfortunately, it's intermittent. You need to inject a cold bolus, and it's not that precise. The smallest change you may trust is 12%. The advantage of these devices is that they, in addition, provide pulse contour analysis estimation because they are connected to an arterial line. And as explained by Bernd Saugel before, the analysis of this curve estimates stroke volume. And the big advantage is that with this technique, pulse contour analysis is calibrated with the previous thermodilation. And so here you have, in addition to the intermittent measurement by thermodilation, you have a continuous measurement. It requires regular calibration, unfortunately, but it's very precise. You may trust very small changes in cardiac output. While with the standard PA catheter, you estimate cardiac output by injecting a cold bolus. You inject it in the right atrium, and you measure a thermodilation curve, not in the femoral artery, but in the pulmonary artery, as you know. It has grossly the same reliability as transpulmonary thermodilation. Of course, it's intermittent. There is a semi-continuous estimation of cardiac output, but which is not real time. It reflects the changes of the last 5 minutes, and it has the same precision as transpulmonary thermodilation. So thermodilation, either pulmonary or transpulmonary, is strongly reliable, unfortunately intermittent, and not very precise. And the advantage here of the PICO, of the volume view devices, is that in addition, they provide us with pulse contour analysis, real-time, continuous, very precise. And it's interesting because this is exactly what we need. For instance, for assessing the changes of the preload responsiveness tests. For instance, during passive leg raising, it's very easy to look at the changes on pulse contour analysis. The movie doesn't work here, I'm sorry. The same for the and expiratory occlusion test. This continuous, very precise measurements of cardiac output are what we need here. An advantage for the transpulmonary dilution devices. Is cardiac output adequate? Of course, we may look at SVO2 or PCO2 derived indices, and here again there is a difference, because with a PA catheter, you sample blood in the pulmonary artery, so it is mixed venous blood. With the other devices, it's a central venous catheter, you just have central venous blood, and it's not the same. Remember the old studies that showed that SVO2 follows the changes in SVO2, but it's not exactly the same. And the advantage is for the PA catheter for sure at that step. Should we give fluid? Of course, it's all about preload responsiveness. It's not our topic today, but as I said before, because the PA catheter only provides, at least today, an intermittent measurement of cardiac output or a semi-continuous but not real-time measurement of cardiac output, it does not allow you to perform the tests of fluid responsiveness. And of course, this dynamic approach of fluid responsiveness is much more reliable than just looking at the value of PAOP. The advantage this time is for the PICO and the volume view. In critically ill patients, for instance, ARDS patients, it's not only the question, should I give fluid, but also what is the risk of fluid? Should I refrain from fluid administration because the risk is too high? Here again, the answer is different. With transpulmonary thermodilution devices, you can estimate lung water. I don't have time to explain how, but when you inject a cold bolus, the device analyzes the transpulmonary thermodilution curve and its logarithmic transformation, and the combined analysis estimates the volume of lymphedema. These are the only devices that do so at the bedside, extravascular lung water. Of course, the risk of fluid infusion with a PA catheter is estimated by PAOP, which is supposed to reflect the capillary pressure in the pulmonary vessels. Is it the same? No, because if you think about physiology and the relationship between lung edema, extravascular lung water, and the PAOP, the pulmonary capillary pressure, it's not exactly the same, okay? When you give fluid, of course, if there is a pulmonary leak above a critical value, lung water starts to increase. But of course, all depends on the lung permeability. All of us could receive 2 liters of fluid without lung edema. It's not the case for severe ARDS patients. It's all about the size of the holes. What is written here is that one given value of PAOP or CVP, by the way, does not tell us precisely the risk of fluid infusion because it does not take into account the permeability, conversely to lung water. Even more, transpulmonary thermodilution estimates the pulmonary vascular permeability, the size of the holes, because it estimates the lung water, as we have seen, but also the pulmonary blood volume of the blood in the pulmonary circulation, and simply divides one by the other. It's the ratio of what is out of the vessels and what remained inside the vessels. And so it has something to do with pulmonary permeability. I don't show the studies that confirm that in animals, in humans. But again, it's a more direct assessment, likely, of the risk of fluid administration. It's more reliable than the PA catheter for this. Advantage to the transpulmonary thermodilution devices. In ventilated patients, especially with ARDS, we want to know whether there is a right ventricular failure. Again, the answer is very different. With PICO volume view, you will look at cardiac output, which should decrease, CVP that should increase in case of LV failure. While with a PA catheter, you have a precise estimation of the pulmonary vascular resistance. And with some of these probes, with a specific algorithm, you may estimate the right ventricular ejection fraction. Again, it's not the same at all here. By just inflating the balloon in the pulmonary artery branch, you have the pulmonary vascular resistance. Mean pulmonary artery pressure, PAOP, and cardiac output. You have the driving pressure of the pulmonary circulation and this right ventricular ejection fraction. Of course, it is a much more direct assessment of the right ventricular function as the one we have with the transpulmonary thermodilation devices. And by the way, it's likely why, or it is why, in the recommendations I quoted before, there is a suggestion that the pulmonary artery catheter should be used in case of acute respiratory distress syndrome with right ventricular dysfunction. Finally, left contractility and the decision to give dobutamine. With a PA catheter, you will look for a decrease in cardiac output, an increase in PAOP, and by the way, a decrease in SVO2. While here, the more direct assessment is for transpulmonary thermodilation devices, which provide you a global ejection fraction. Indeed, with these devices, you estimate stroke volume, but also the volume of the 4 cardiac chambers at end diastole. This combined analysis of the thermodilation curve and its logarithmic transformation estimates many intrathoracic volumes. And here is the volume of the heart at end diastole and of the and stroke volume. In fact, it's not very far away from the LV ejection fraction you assess with echo, because it's not the global end diastolic volume, it's the LV end diastolic volume. But the advantage over echo is that it's really a monitoring device. You can easily repeat it, okay? So here, the more direct assessment of the LV contractility is provided by these PICO volume tube transpulmonary thermodilation devices rather than by the PA catheter, which provides a quite indirect estimation. At least it tells us that, to take our algorithm back, the monitoring devices we use may depend on their availability, on the use of the team. The team must be used and skilled in using the PA catheter. It's quite difficult, or the transpulmonary thermodilation devices, and of course on their availability. If they are not available, okay, you can do with echo, but echo for me is not a monitoring tool. I mean, how many echoes are you going to perform in one patient in one day? In the patient, I took the example of this shock patient on the first day. How many echoes your patient will have within 24 hours? 1, 2 maximum. It's not monitoring. But if the devices are present, and if it's possible to use them, you may choose either the PAC or transpulmonary thermodilation devices, and both are possible indications. You understood that I prefer the transpulmonary thermodilation devices, but there is clearly an indication for the PA catheter as well. The PA catheter is better for assessing SVO2, the true value, and the right ventricular function and right ventricular afterload. TPTD is better for assessing fluid responsiveness through the test and dynamic approach and the risk of fluid infusion through lung water. Thank you very much for your very kind attention. I'm open to your questions, of course.
Well, Xavier, we thank you for that excellent lecture and for sharing your wealth of knowledge again with us, and also giving us a very practical summary of what to do clinically. And I think you also presented us with very interesting data that challenge us, our own assumptions about how we conduct monitoring today in the ICU. I have quite a few questions here. I'll try and collate them so that they are all in reasonable order. But perhaps I will start off with you, Bernd, and ask you whether you think the gold standard of blood pressure monitoring is invasive arterial blood pressure.
For sure it is. It's a direct measurement of blood pressure using an intra-arterial catheter remains the most direct and reference method. Of course, it is kind of invasive, but if we look at the data, major complications are really, really rare, especially if you use the radial artery for cannulation. On the other hand, of course, we cannot insert an arterial catheter in every patient having surgery, and that is probably not necessary. But in those patients, we should at least measure intermittent blood pressure high frequently. That means every 3 minutes, for example, or we may use continuous non-invasive technology. The most important thing is that we are aware that hypotension is a problem and that we need to measure either continuously or high frequently. And we need to avoid a longer duration of low blood pressure. That means we need to avoid profound intraoperative hypotension.
Right. So that I would agree with you. But with the new technology, finger cuff technology that you presented today, that seems to agree quite well with the invasive blood pressure monitoring techniques. Would you be advocating that over an invasive arterial line?
I would never say that it should replace the arterial catheter. I think the arterial catheter remains the standalone reference method. In my personal view, think that the continuous non-invasive finger cuff methods may or should replace intermittent non-invasive measurements. So to be very precise, the finger cuff technologies may replace the oscillometric upper arm cuff. They are probably better regarding the measurement performance in terms of they agree better with invasive measurements than does the upper arm cuff with invasive measurements, and they provide measurements continuously. So there are two advantages, probably superior measurement performance, even though of course we need more data on this. But for sure, and this is kind of a no-brainer, if you measure continuously, you you detect hypotension earlier.
Great, thank you for that. It does seem like a no-brainer, but I still hear arguments every day. I have an excellent anesthetic nurse, and they have 20 years of experience, and they're better than any monitoring technique that we'll ever be able to use. So perhaps it's time to change. Thank you for that. Okay, and I have an interesting question for you, Xavier, and I'm not sure if I understand this question. I'll read it out to you directly. When determining the type of hemodynamic monitor to use, should we not be looking at whether the system is based on flow measurements and hence not affected by changes in arterial compliance, plus whether the measurements are done peripherally or centrally? I'm not quite sure what that means, because as far as I learned from your lecture, even the flow-based measurements are affected, or well, they are very much affected by arterial compliance. Can you just confirm that?
In fact, not really. The only flow measurement which is affected by the arterial properties, compliance, but compliance is stable in a given patient. It's only determined by age, okay, and hypertension. So, but mainly resistance. The only cardiac output monitoring technique which is influenced by arterial pressure is pulse control analysis, okay? And for sure, it is affected by arterial resistance, and when arterial resistance changes, cardiac output drifts away from its reference, from the true value. The advantage of pulse control analysis we use in the ICU is that it is calibrated by a reliable technique, by transpulmonary thermodynamic. So it is true that you have to recalibrate the system, and if you don't do that after a few minutes, after 1 hour, the value you see on the screen is not the right one. You must recalibrate. But in the meantime, on short lapse of time, you can rely on that value and on its changes. Transpulmonary thermodilution, the PA catheter thermodilution are not related themselves to arterial compliance. Flow is independent from the arterial properties for these thermodilution techniques.
Okay, well, thank you for that that excellent answer. I hope that answers the attendees' question. I have a related question, and I know that you did mention this in your slide, but perhaps it would be useful to repeat it. For patients with ARDS and right ventricular dysfunction, should we choose PICO or the pulmonary artery catheter?
Both has advantages and drawbacks. I like the PICO device or the EV1000, the volume view device. Again, these devices are similar grossly because they provide lung water and lung permeability, and it helps me in fluid management. Every day, the question is with these patients, should I give fluid or not? The patient has low blood pressure. He or she is fluid responsive, but the PF ratio is 100. Should we give fluid or not? To answer the questions, I like using lung water and lung permeability. But in case of right ventricular failure, in this small amount of patients with right ventricular failure, 20% of patients with ARDS have acute copulmonary, then the PICO volume view are not good at estimating the right ventricular function. The only device that measures arterial pulmonary artery pressure directly and resistance directly is the PA catheter. So in this proportion of ARDS patients with RV failure, I would need both a PICO and a PA catheter, but it's very invasive. So I would prefer a PA catheter in this specific indication. Nevertheless, you can use a PA catheter in any cases if you like it, and etc. I told you my preference.
All right. Well, thank you for that. That is more or less how we do it here in our unit in Sweden as well. I have a related PA catheter question, perhaps for Bernd. When would you use a PA catheter in the OR?
Well, clearly in patients having cardiac surgery, and that is one of the classic indication, and we still do that quite frequently. In non-cardiac surgery patients, we kind of have the problem that there is a really bold statement that I showed you in my presentation from our European Society that routine PA catheter use is simply not recommended. That means you need to have a good argument, a good indication to use it despite the recommendation to not use it. So we do use it in patients or in selected patients having undergoing liver transplantation, but we mainly use transpulmonary thermodilution and sometimes transesophageal echo in those patients, but there are some patients who may benefit from it, especially in the case of pulmonary arterial hypertension, right heart failure. And there may be some patients with a history of right heart failure that have to have non-cardiac surgery, major abdominal surgery, for example, in whom it might be good to use a PA catheter, but honestly, those are probably a handful of patients per year in our institution.
May I ask a question to Bernd? Are there some departments, I'm not an anesthesiologist, as you know, which use the PICO device or the volume view device instead of the PA catheter in cardiac surgery during the intervention, not afterwards?
Some use it, for example, in lung transplantation, but that is, of course, a very specific indication, and we do that too, because in those patients, extravascular lung water is an interesting variable. During, let's say, more often performed cardiac surgery, valve surgery, CABG surgery. I'm not aware of institutions that routinely use transpulmonary thermodillusion instead of the PA catheter, because especially cardiac filling pressures are interesting during off and on pump cardiac surgery. So here we are more interested in cardiac filling pressures than actual cardiac output measurements. And of course, we have a transesophageal echo in every single one of those patients, so we know a lot about cardiac function in these patients. Michelle, what do you say? Do you agree?
Yes, I do agree. And just the fact that the patient goes on cardiopulmonary bypass, of course, it's a different matter if they're on the OPCAB. But the fact that patients are on cardiopulmonary bypass, it really complicates the method, the measurement method. So I don't think I'm not aware of any institution that uses a PICO over the pulmonary artery catheter. There are a lot of questions rolling in, so you guys will be busy, I think. And here is a really interesting question for both of you. What is your guidance regarding hemodynamic monitoring in resource-limited areas?
It's if I may start, it's a very important question, of course. First, bear in mind that there is a lot of hemodynamic information in the arterial pressure signal. Vasomotor tone with the diastolic pressure, stroke volume with the arterial pulse pressure. So it's basic monitoring that is useful. CVP is interesting. Second, echo, if it is possible to have an echo device, and today there are cheap echo devices, is for sure, even if it's not a continuous monitoring device, as I said, is for sure very helpful, very helpful. In the ICU, this is what I would answer. In the OR, it's the turn of Bernd, of course.
Well, it's more or less the same answer. Of course, the invasively measured blood pressure signal gives you a lot of information about cardiovascular dynamics. And then I may answer, because it's an important statement towards industry. It's those non-invasive technologies are very, very expensive at the moment. So, and coming back to what we said earlier, if we think that from a medical perspective, those non-invasive systems would replace or and not invasive measurements, then of course they need to be provided at a comparable price, and that is not the case at the moment. So for limited resource settings, I totally agree that especially those innovative technologies are not an option. Honestly, they are even not an option in high resource settings outside of surgery and outside of clinical studies at the moment. So I think we can agree on the answer. Then we need to look at the blood pressure signal.
Right, and that's a very practical answer, very important and thought-provoking question. With us living a very luxury and very protected life in a university hospital setting. So thank you for that question. I know we're running out of time. I know that this webinar, or the contents of this webinar, will be available to all attendees, and perhaps you'll find many of your answers in some of the slides. But I would like to round up by asking one last question. Is there a way of performing hemodynamic measurement using a smartphone?
Bernd.
Indeed, there is. There are some applications available that, for example, allow you to perform pulse wave analysis from a screenshot just by taking a photo of the regular patient's monitor with your smartphone. But at the moment, as we are still trying to validate non-invasive methods that are directly attached to the patient, I would say that those completely contactless devices, that may be the next step in towards, well, it's not even non-invasive, it's contactless, are just in their very, very early phases, and we need more data, better applications, better algorithms. At the moment, that is something to play with and nothing to really base your clinical decisions on in clinical practice.
It's even more true in the OR because, as I told you, it's likely the place for sophisticated and invasive devices. Nevertheless, I know that the constructors of the PA catheter Edwards and of the transpulmonary thrombolution devices, Pulsion Edwards as well, work on some display of the screen and of the data on the smartphones with algorithms for interpretation, etc. For sure, things will change in the future with totally different devices and with AI a lot in these devices. I don't know if it's a big progress, but for sure, it will occur in the very next years.
Yes, and we all look forward to that. And this may be one of the ways that we can address how hemodynamic monitoring should be done in resource-poor settings. So with that, gentlemen, I want to thank you. I'm sorry we've gone a little over time. I really want to thank you both for sharing your wealth of experience with us and summarizing all that data. I think it'll take me at least a month to go through all the papers that you've presented today and presenting it in a form that's clinically useful. I know that there were very many other questions on the chat. I'm sorry we weren't able to answer all of them. Thank you for joining us, all of you. Take care and keep safe. Thank you, Bernd and Xavier.
Thank you very much to all of you. Thank you, Michelle. Bye, Bernd.